Hello, everyone, and thank you for joining me for this MASLD Gap APP Insight. My name is Lavinia Iordache. I am a physician assistant with 10 years of experience in outpatient and inpatient hepatology, and I am affiliated with University of Miami. I'm happy to be here today and answer a few of the common questions that we receive from our colleagues in local gastroenterology offices, and we will go right into it. So these questions usually go beyond the topic of diagnosis, how do we diagnose and how do we do the initial management of fatty liver disease. They're more geared towards management and monitoring of the patients who are suspected to have more advanced fibrosis. So one of the questions we usually receive is how do we confidently monitor patients in the GI clinic for onset of advanced fibrosis, and when should the liver biopsy be pursued? So patients with low risk for advanced fibrosis based on the NITs, such as those with a low FIB4 below 1.3, can be monitored with routine testing, probably labs every 6 months, to assess for any liver enzymes abnormalities and other markers, and repeat the NITs after 2 to 3 years is what is currently being recommended. Sooner in certain cases when there is more concern. And a quick note on liver biopsy here, we know that fatty liver does not happen in isolation, and it can be, concomitant with other liver diseases such as autoimmune or viral hepatitis or other metabolic disorders. And in certain cases, whenever the liver enzymes are persistently elevated, despite the improvement in lifestyle changes, diet, exercise, we should consider a liver biopsy to exclude another etiology and appropriately treat that patient in addition to the usual management for MASLD. So there is still a role for liver biopsy, even though we are not really using biopsies right now for staging as much as in the past. In the past, we used to think that liver fibrosis was static. Now we know that it's more fluid, and the liver fibrosis can fluctuate over time. It can progress, it can regress depending on what's going on at the cellular level. So we are moving away from liver biopsies, but there is still a role for that. Second question, when should a patient with liver fibrosis be referred to hepatology versus continue management in the GI clinic? So this is really up to the discretion of the GI provider. I think most are comfortable managing patients with stage 1 to 2 and even start patients on resmetirom and monitor patients on treatment. We see a lot of referrals for stage 3 patients whenever there is a concern for faster progression of liver disease, patients with other risk factors. And, that's when we should be more proactive about treating these patients and monitoring for complications such as hepatocellular carcinoma. How often should imaging be performed in patients with MASLD and MASH, and what is the preferred imaging study? So currently, AASLD guidelines recommend HCC screening in patients with cirrhosis only. However, we know that the high percentage of MASLD-related HCC occur in patients without underlying cirrhosis. So we know that it's very important to screen even patients with F3 fibrosis, and EASL recommendations currently are along those lines to screen patients with F3 based on an individual risk assessment. So we have to consider other risk factors that the patient might have, such as genetic predisposition, any family history of liver cancer, tobacco, alcohol use become important. And even in patients with diabetes, especially uncontrolled diabetes, there is a 2 to 4-fold increase in the risk of HCC. So importance should be paid to that as well. And in addition, the method, the modality of screening is also important because MASLD patients tend to be overweight, and we know that increased central abdominal obesity and subcutaneous fat layer will prevent ultrasounds from accurately assess for HCCs, and actually 41% of HCCs can be missed by ultrasound. So we do like to employ a cross-sectional imaging such as CT or MRI in this patient population. So I'm happy to answer any other questions from anyone else. I'm always happy to interact with my colleagues in local GI practices and other specialties as well, and to share and exchange information about MASLD patients. Again, my name is Lavinia Iordache. Thank you for your attention today, and hopefully we'll be in touch soon. Looking forward to meeting you. Thank you. Bye-bye.